Okay, now I'm gonna flex a little bit so you guys trust that I know what I'm doing. So it's in the program, you get 2 dedicated blocks. Before that, you have a whole bunch of courses. For those during this who have the summer session, for campus semester, it's supposed to be easier, but often you don't study during that summer. So me and a couple of friends took step one after about a month and a half of studying. And we didn't use our entire research elective. In fact, most of us on the dream board, we just studied concurrently with behavioral self-help. It's extremely hard. That means there's an extreme amount of time management that occurred for me and a couple of other students. And so what I'm teaching you now and what I want to get across to you is that I'm not necessarily teaching you how to get a 280 on step one. As you guys know, step one now is pass fail. I'm trying to get you guys to maximize your time studying so you don't have to waste multiple blocks trying to study for this test. That's pass fail now. Second thing I want to do is encourage you to pay attention to the high yield concepts because they're gonna reoccur on step 2 CK, which matters a lot more now. And with whose numeric value actually can determine which residency you go to, unfortunately. Is that fair? You guys trust me? Okay. So this is just general step one advice. If you carry this advice forward with you, I'm positive you can pass step one and study efficiently. If you don't carry this with you, you can still do it, but there might be time in between where you're just learning how to study at all. And that's a disservice to your time and a disservice to the work that you have committed yourself to. So step one consists of 7 distinct 40-question blocks, 1 hour per block. And you get a 1 hour break in between. The reason I'm telling you this is because the practice material you'll have available to you, that's CBSEs, offline MBMAs, and New World self-assessments, and even free 120 will be very different from that. And in fact, CBSE, MBMAs, and New World self-assessments will consist of 4 blocks of 50 questions, which are 1 hour, 15 minutes per block. Regardless of all that, you need to learn to read. You need to learn to read fast. And that's something you should be concentrating now. We're going through pathology, while you're doing research, while you're doing whatever you're doing in your courses, is learn how to read and learn how to read well and fast. And the reason why I'm saying that is because step one is like essentially 3 types of questions from what I've noticed in morphology. And most of them require you, even no matter what anyone says, most of them require you to read the entire question and know what's pedantic detail, meaning a detail that's just there to decorate, or a detail that actually matters for answering the question. Does that all make sense? Okay, so our program specifically, when preparing to take the USMA step one, you get 2 dedicated study blocks. There's a pre-CBSE and there's a post-CBSE. So the pre-CBSE is a pre-test to determine if you need the study blocks at all. If you get over 66% on the pre-CBSE, you're ready to sit for step one whenever you want. I encourage you to do that because then you get an extra 2 blocks. You essentially get an extra 2 blocks to do research, to relax. If you have spring semester, it means you can just go and have vacations, which you'll need after the amount of rigor you'll go through for the pathology and pharmacology and behavioral health student. So I would really consider trying to get above that 66 baseline of the pre-CBSE. It's okay if you use up to 2 study blocks, but I would really encourage you not to postpone and go further than the 2 study blocks. Why? Students who tend to postpone their step one and their post CBSE and push that deadline further and further, end up taking it in the summer of their 3rd year or their 4th year, which is disservice to the electives you're taking concurrently and pushes your timeline for future electives and sub-internships too far. And so just general advice, try to take a step one as fast as possible, just as fast failing. That's what they're encouraging you to do. Not saying that's not important. The material will occur on the step 2 CK, but I'm encouraging you with that. There's a lot of resources out there. Don't use all of them. Stick to 2 or 3. Even just stick to 2. That's why I tell people all the time, just stick to 2. And the reason for that is if you get pedantic about all the resources you have and use all of them, you will just be a person who's wide but not deep. And step one requires often that to be true for you to be wide and not deep. But whenever you get to the deep questions, you'll just ultimately be unable to answer them at all. And so there's UWorld, MBMEs, OnKeen, 30 medicine. These are the top ones here that I've listed on the slide. If you're like, I don't know which of those to even choose, there's like 7 on there. So yeah, what do I do? Just do UWorld and a form of OnKeen. Okay, just do UWorld in a form of OnKeen. And eventually you'll get to the offline MBMEs. So that's probably what's best. Finally, there's three types of morphological questions in the step one. There's think versus know versus do not read. What do I mean by that? There's some questions that you don't, there's no way you're going to even hit that in the U world or the Anki, and just you have to think about it. Things that are basic physiologic or histologic questions about um, how the body reacts to pathology. There's also no questions. What are no questions? There are questions just you need to know the facts and you need to know how the video will present itself. And finally, there's the do not read. There's questions that have like paragraphs of information. And the final question is something you can answer on its own, like what type of receptor is insulin receptor, so say like tyrosine kidneys, right? Or something like that. You did not need to read this pedantic paragraphs full of like someone with insulin deficiency or something. So those are the three types. Up to this point, does anyone have any questions? Otherwise, I'm gonna go pretty quickly through these. You sure you guys don't have any questions? It's pretty scary. I know that you're secretly always thinking about this. Okay. Does anyone want to read and then try to answer this question at all? It's not super hard, but if you don't remember your HSF form, which I've tagged here at the bottom, you won't remember it. Okay, I'll read it, and then just gonna force someone to answer it. Don't Google it, Christina. Don't Google. Christina, I know Christina's trying to Google this. Okay. So a 55-year-old patient presents with the following physical findings seen in the above. So notice this physical finding. Some questions will determinately expect you to know exactly what's occurring in the exhibit or the image, okay? The patient has a past medical history of stage 2 breast cancer, diabetes type 2, and hypertension. Patient has a heart rate of 62, BP of 142 over 90, and a resting respiratory rate of 12 or 12. Physical findings worsen when patient pushes against the wall. Which of the following is damaged? Does anyone have a guess? You're getting pedantic. Don't get pedantic. Just go with your gut feeling because you know this. You've learned this at some point. It's extremely high yield.
Is it long thoracic?
It is long thoracic. How'd you figure that out?
Because it's the wing, the scapular wing. When you push against it, comes out.
Yes. So two buzzy things for long thoracic nerve dissection is of course the weak scapula. Another thing you could have noticed is that this patient used to have stage 3 breast cancer, but maybe they went through mastectomy. So often we think about incisions along the axillary line. If there's any sort of trauma in that area, just start thinking it could be a long thoracic injury. So post mastectomy and doing scapular high yield for that. I was just gonna say I'm gonna post these slides eventually. And for you all, I'm gonna post these notes. I'm gonna send them to you. I'm asking you to send it to you guys that I have based on our talk. You should make Anki cards off this. If you're not studying for step, you don't know how. We have no regimented step therapy like studying right now, which makes sense. Just where you guys are at. Make Anki cards based on our discussion because I promise you, I am not wasting your time. This will all be on somewhere on the MBMEs, CBSE, or on your actual step. So I'm not gonna waste your time in that sense. So post mastectomy, um, wing scapula. I'm gonna go through a couple of the other answers and why they're wrong or right or things you should know about them. Spinal accessory nerve to the trapezius. What do you guys know about that? So let me ask you a question. Is it a special type of nerve and why? Okay, no worries. This is super hard. This is actually cranial nerve 11. I know it doesn't look like that because you've never seen it probably written out like this, but it's cranial nerve 11. And the reason I put it on here is for a couple of reasons. One, I wanted you guys to get used to looking at answer choices that are like that are existing things, but they just don't look right because you've never seen them written out that way. USMLE likes to do that a lot. Second, I wanted to go into a small discussion about cranial nerves because they're extremely high yield. I know this is MSK, and that's not necessarily something that you would think is high yield, and it's definitely not for MSK, but I just think cranial nerves are very, very high yield. So one thing is you should look up just an image of the cranial nerves dissected along the brainstem, and you should just memorize from top to bottom what's cranial nerves 12 to 1. It seems very pedantic, but they do test on that. They'll give you some sort of dysfunction and ask you to label, like, know which nerve along the brainstem is a cranial nerve. You should also know that cranial nerves 1 and 2 are central nervous system nerves versus peripheral nervous system. You guys know what that means? So central nervous systems like spinal cord and brain, right? And there's peripheral nerves like your femoral nerve or your brachial plexus. All the cranial nerves are part of your PNS, meaning your peripheral nervous system. But, and you should maybe start thinking about your HSF1, HSF2. Your cranial nerves 1 and 2 are actually part of your central nervous system. This is on a UWorld question. And I think there's a question floating around somewhere among the MBMEs that tests on that exactly, that you didn't know cranial nerves 1 and 2 are central nervous system. Although they don't like just test it like that. They'll be pedantic about it. Does anyone know what the spinal accessory nerve, the trapezius, other than the trapezius, what else the spinal accessory nerve innervates? Just guess. I'm not going to answer this time. I'll be silent until someone guesses.
Wait, low key, I could be wrong, but isn't it like sternocleidomastoid or something? I feel like I read that on like Reddit.
Guys, you just let a first year beat you. Just
No,
absolutely.
Reddit hasn't said me wrong.
It's absolutely the sternocleidomastoid, which helps you do this kind of rotation. And that's about all you need to know for that nerve. I was gonna get the cranial nerve to be pedantic, but for the sake of time, I'll run through these pretty quickly, just because I want you guys to get really big concepts down, because each concept that you learn, even just one fact, will be one question likely in USMLE. 3, muscular to cutaneous. You guys know what that innervates? This is pretty easy. You guys got this. So just remember HSF1, musculocutaneous, think it through. So musculocutaneous is, let's say, a nerve of the arm. What's like the muscle you think of the arm? The arm.
Coracobrachialis, like the coracobrachialis.
Okay. Yeah, keep going.
Uh, biceps brachia, I guess.
Biceps brachii. Yep, yeah. So how a musculocutaneous is likely going to be tested on the USMLE is they will give you a patient with arm trauma that can no longer flex their arm. So that's the main, look at that. Guys, that's real. That's years of training in the gym. They'll test that on the USMLE. They say someone can't flex their arm, what nerves are dissected. They'll either just directly put musculocutaneous, or they'll put something pedantic like C5 through C7, which happens to be innervation for musculocutaneous. So that's how it's going to be tested on USMLE. And that's about it from that point. There's other things we could talk about, but I think we'll just get into details you need to know. 4, phrenic nerve. Does anyone knows what that innervates? Oh my gosh, you know what the phrenic nerve is. Someone Google it. Someone Google it so I just hear someone's voice that's not mine.
Red diaphragm.
The diaphragm, the phrenic nerve, innervates the diaphragm. It's from C3, 4, and 5. So anytime we think about, trauma to mediastinum or down at least to the intersection between the lungs and the abdomen, we think there might be a phrenic nerve issue. Now there's 2 phrenic nerves, so there can be either a bilateral or a pseudopalsy of the diaphragm. So remember that there can be either half of the diaphragm being paraplegic or plegic, not paraplegic, plegic, or they can be both sides of the diaphragm being plegic. One thing I want to mention that's extremely high yield, this has nothing to do with MSK, is if you get a baby, this is going to be on your USMLE, this is going to be on MBMEs, and this is going to be on UWorld. If there's a baby with a radiographic image of guts inside of their pleural area, then the answer is like a failure of the, I forgot what it's called, but there's sometimes congenital deficiencies in which the diaphragm doesn't fuse, or it's open, in which the guts can spill through into the pleural space. And I didn't prepare for this, but I was just thought about how high yield it was. I forgot what it's called. There's like a specific answer choice that maybe I'll remember next month. Suprascapular nerve. What is that innervate? This is super easy. If someone doesn't say anything, I'll think that you guys are paying attention. I'll try camera.
It's the supra and then infraspinatus. No, I remember that, Malin.
Yeah, it's super scapularis or whatever.
Scapula. Oh.
Yes.
Oh
This
yeah.
is, yeah, what were you saying, Christina?
Oh no, just I thought I was tweaking. Never mind. Go ahead.
Does anyone know how this presents? This is extremely highly for the UMSL. I think I've seen that at least 2 or 3 MBMEs. Definitely saw it on my stab. I think I saw it on the CBSE. If there's any patient that comes in to the office with one of these questions and they can't abduct their arm, and they have a positive empty can test, like they have pain when they're abducting their arm and pressure is put on it, you just put, like supraspinatus or whatever. What is it called? I don't know. Whatever. You guys don't test me. Don't test me. But just put something along that idea. Okay. Here we go. I have notes, by the way. I didn't not prepare for this. So many notes. This one's a really
proud of
hard
you.
question. There's no way you guys are gonna get this question. Thank you, Christina. Does anyone want to read it, guys? I hate my voice. I'm not gonna lie.
Okay, I can read it. Wait, let me turn my light on. Okay, a 32-year-old male patient presents to the clinic for follow-up. Patient is paraplegic from a motor vehicle accident during a road trip. Patient has a BMI of 15, heart rate of 60, blood pressure of 117/77, and a respiratory rate of 12. Patient is accompanied by his family. Patient is febrile with the temperature of 100.1 Fahrenheit and is tachypneic. The CXR demonstrates polymicrobial abscesses of the lower lung, which the following is likely contributing to the muscular atrophy.
You guys think? You're probably like, what in the world are all these words put on the screen together? We did not learn this during Path 1. You're right. You barely learned this. Whoever gets this question right gets 5 sandbugs. Now, what is a sandbug? Great question. A sandbug, if you have 25 sandbugs, you get 1 super sandbug. And if you have 1 super sandbug, you can ask for a Chipotle bowl from Sam, and Sam will buy you one. Yeah. Why don't someone just throw something out there and then make a guess of why they might be right? Tina might be screenshotting this and putting this to ChatGPT. We don't know.
Well, hey, I don't. I'm not giving the data to China. You know.
What do you guys think? There's this image I saw on Instagram of like DeepSeek AI. And if you ask DeepSeek AI to say that Taiwan is like its own country, they'll put Taiwan as a part of China.
Do you mean Chinese Taipei?
I just forgot this is going on YouTube though. People don't see what I was saying. I should probably say better, more substantial. Okay, I'm just gonna choose someone. Alicia, you're going. You read the question, you're answering the question. How it works. How it works.
Okay. Wait, I genuinely don't know, but maybe necrosis because there's abscess of lower lung. I don't know.
Okay, so that's exactly what I wanted you guys to think was right. So well done, you fell into my trap. This is questions called a do not read for a reason. Sometimes there's questions where they're asking a very simple question about something that's like a histological truth, but they put all these pedantic details about pathologies you don't need to know about that the patient has just to trip you up. And all you really need to do is read the last question. So sometimes, not always, reading the last question first can help you understand what's actually being asked. So in this case, they're asking about what happens when you denervate muscle. So the patient's just sick. I mean, paraplegic, just sick. It could be asking about the abscess and the pneumonia. What's likely being asked right here is the patient's paralytic from a motor vehicle accident during a road trip. Why does the muscle have atrophy? What's denervated, meaning They're lesions to from the central nervous system to the actual muscles. Really high yield. Polyubiquination is the answer for it. Okay. When you denervate muscle and there's muscular atrophy, proteins within the muscle get tagged. So this is high yield for what the ubiquitin proteasome pathway looks like. Proteins get tagged, the cellular aspects get tagged, and then proteasome goes out towards that area, sees the tagged part of them simplifying it a lot, and eats it up and like destroys it. Okay. And so that's what happens in muscular atrophy. Now, necrosis is a great answer. Necrosis, hallmark things you want to know from pathoma is that it's associated with cellular damage. That's somewhat high yield, not super high yield. You should know the difference between necrosis and apoptosis. Apoptosis is often like substantially more like thought out than necrosis. Necrosis is often pathological. Apoptosis is often physiological. Okay, apoptosis, what you'll notice on histology is red nucleus. Okay, there's actually a CBSE question I think me and Risha both agree on. Was apoptosis alone because all they wanted you to see was there's an image with a red nucleus. Crazy. It's crazy stuff like that out here. There's also different types of necrosis that I want you guys to make note of if you're taking notes or if you're thinking about it or memorizing. The main ones I want you to know from just this one is coagulant necrosis, liquefatic necrosis, caseous fat, and fibrinoid necrosis. I'm going to get into fibrinoid necrosis here in a second. Coagulant necrosis, what happens in ischemia? In every organ except for the brain, when there's ischemic attack, like an infarct, like a renal infarction, you'll see coagulant necrosis. If there's the liquefatic necrosis, you should automatically think the brain. If the brain has a stroke or any sort of ischemia, you've got to start thinking liquefatic necrosis. And we could get pedantic with having histologically, but we're not going to get into that detail here today because we're almost, even now, we're almost out of time. There's also caseous necrosis, which you guys probably think immediately to tuberculosis. That's a good association to have. And that's an answer sometimes on MPMEs and UWorld. It's just caseous necrosis when the patient has a TB vignette. Fat necrosis occurs in the pancreas and the saponification of fats when there's pancreatitis. Just remember that. And fibrinoid necrosis happens in vasculitis. So I'm going to go through some of the vasculitis really quickly because you just learned them. So they should be fresh in your mind. Does anyone know what the large vessel vasculitis are? Okay, no worries. We're just going to talk about one. There's two: giant cell arteritis and Takayasu arteritis. Can anyone tell me about giant cell arteritis?
Wait, I actually like just read
The
about this like
temporal one, it happens in people over 60, and it presents with jaw pain, headaches, and you should use steroids for it.
Fatima, do you have anything to add? That was
Yeah.
great.
no, yeah, it was like yeah, everything she said too, pretty much. Yeah.
Absolutely. So they're going to give you a vignette. It's going to be a 6-year-old woman. She's going to have jaw claudication. It's not going to say jaw claudication. It's just say pain while eating or pain while opening mouth or just like unilateral pain on the side. Okay. And they're going to ask you what the best next therapeutic step. This is more like for 2CK, but you need to know that out of all the vasculitis, this giant cell arteritis reacts to corticosteroids. Okay. You also need to know that it's a granulomatosis inflammation. So granulomatosis necrosis. Okay. Wow, that sounds really cool. Granulomatosis necrosis. Okay. So it's an important thing to notice on histology if you can. That's granulomatosis necrosis. Okay. And there's other things we can talk about. We're just getting pedantic. Median vessel vasculitis, Kawasaki disease is the one I'm going to talk about. There's also polyarteritis nodosa. It comes up less on the step, which is why I'm ignoring it today, but also just because we're running out of time. And I want you guys to just review the vasculitis as much as possible. Why? Because I would say in every block, one question is a vasculitis. That's how high yield it is. It's saving you one question. Okay. Kawasaki disease, does anyone remember how that's pronounced? You don't have to, but just try your best.
Then kids like below 5 usually fever, like strawberry tongue, and I think their lymph nodes are inflamed and the aneurysm risk for coronary arteries.
That's absolutely right. Often they won't get super pedantic about details, but you should just be able to identify like strawberry tongue, cervical lymphadenopathy, things that would make you think. So once you get into step studying, you'll be able to start thinking of those things as like rheumatic fever, right? But no, the answer will be Kawasaki disease often. If it's on 2CK, you should even do things like I think it's like angiography to make sure that there aren't any clots, because if there are, you want to start prescribing aspirin. And you don't often want to prescribe aspirin in children. Do you guys know that? There's something called Rye syndrome or something. There's some kids who have like a reaction to aspirin. I'm forgetting now because I'm so far out from STEM. I would have remembered this 3 weeks ago. But they have a reaction to aspirin, so we want to avoid that in patients other than if they have Kawasaki. And it's necrotizing arthritis with inflammatory infiltrates in medium-sized vessels. So that's how we want to see that on histology. I'm gonna skip through all the small vessel vasculitis because we're just running out of time. But I want you guys to know that IgA vasculitis and cryoglobulinemic vasculitis are two very high infections. IgA nephropathy and IgA vasculitis are extremely high. So just remember those. And I actually, on my step, I actually got a beset disease question, so know that too. It's like a vasculitis that also appears on like the genitals. If you just see vasculitis, it also looks like an STD. Just start thinking beset. Okay, and the answer will just be beset. I don't think they'll ever get pedantic about what it exactly is. Fast ligand-driven cell death, just to go really quickly, just to save your guys time. This is like lots of detail at once. It's what's going to be the negative selection in the thymus for T cells. When there's deficiency in fast ligand, there's different pathologies to present, including ALPS. And I don't remember what ALPS stands for, but it's there's too many T cells, okay? So this is all appearing on YouTube, so I seem like an idiot, but you're just gonna have to deal with that. And it's apoptosis driven. So fast ligand driven cell death is apoptosis versus pathologic cell death, which is often, let's see. I caught her in the moment, she wasn't paying attention. It's necrosis, okay? The answer was necrosis. Lactic acidosis is going to come up a lot. I just want to talk quickly about metformin because it's semi-high yield and because you'll see it on your pharmacology class. So when you get to pharm, it won't be like a new concept. Lactic acidosis is associated with metformin, specifically metformin in those with renal function issues. If the patient has renal function issues, like a creatinine of like 2 and like a PUN that's just like this crazy high, I want you to start thinking, okay, it could be lactic acidosis from metformin, especially if you have type 2 diabetes. In pharm, they won't get pedantic. They'll just ask you like a vignette about metformin and the patient has like some weird, lab values. You start thinking lactic acidosis, but on step, they won't tell you any of that. And they'll just show you the lab values. And you got to expect to know that they have renal failure. We have to do this. Okay. Who wants to read this question? I don't know who hasn't talked a lot. I've bullied plenty people, I think, at this point. Christine, it's been a long time since I've heard you talk. So
Damn, a long time. Okay. An 18-year-old female baseball player comes to the emergency department after an injury on the field. Patient has a closed fracture of the arm. After surgery, neurologic examination is normal except for reduced strength and extension of the forearm and wrist extension. Which of the following is likely the origin of fracture?
don't let your brain compete with your gut on this one. Just go with what you think is right. Christine, I just realized how good this is for you. And I think Fatima too, she's in or they said they're in first year because like you haven't gone through HSF yet. You have no idea what it says HSF here on the bottom. You're like,
No, yeah, we're 280 plus on step. We're gonna be powerful.
that's just begging. Okay, Srija, you've been thinking. You look like you're thinking. You're on the thinking mode.
Is it radial groove?
It is radio group. Why?
Wait, did you say something? I can't hear anything.
Oh, can you hear me now?
Yeah, sorry.
It's 100% radio group. How did you figure that?
Because extensors is for the radial nerve and that runs through the radial groove.
Exactly. So in questions that I like label as think, you don't have to know everything on Earth, right? And often you won't, especially when you're taking the pre-CBSE, you won't feel like you know everything. But you know certain truths. And if you can pull those truths together and word associate, you win. So for example, on this one, what is it? Can't extend. So if you can't extend, you think thinking, okay, radial nerve. If you think of radial nerve, then what's the only thing with like radial in it? The radial group. So that you just click that, okay? Of course, Rita knew a little bit more than that because she's smarter than me, but that's how I would think question. Okay. Let's go through a couple of these. So surgical neck of the humerus. Yes. That's going to be damaged. If there's a fracture, there's going to be damage to the axillary nerve, meaning you have flattened deltoid and diminished sensation right here. Okay. Supracondylar region, what is it? Supracondylar region is often a pediatric fracture. Okay. It can injure a lot of things, but what it's going to injure mostly on the USMLE will be the median nerve. Okay. So think of like things of carpal tunnel, like carpal tunneloid, habitus. So like, weak pulse, dusky hand because of the, I'm reading off my notes here, so now I'm like getting out of my head. Because of the damage to this vascular structures here, but also you'll see things like weakness as like in your thenar region, right? Diminished sensation, these two. So start thinking that. Radial group, we just talked about radius nerve. Proximal ulna, that's just a distractor. Sometimes there's distractors on these exams. Answers that will never be right. Proximal ulna in this case is like one. This one's super hard because you've likely never ever seen something like this. Does anyone want to read it? Okay, Siri, you're reading it. Siri deserves to talk too, guys.
A 16-year-old boy presents with a 2-month history of progressively worsening pain around his left knee. He notes that the pain is most severe at night and is not significantly relieved by over-the-counter analgesics. And on physical examination, there is noticeable swelling and tenderness over the distal, sorry, I can't see, femur, and the overlying skin is warm. Laboratory results show elevated alkaline phosphatase levels. The following radio image is seen. Where is the most likely metastasis?
Who wants to just guess? Let's just shoot out guesses because this one's like.
Was it liver?
Good guess. Unfortunately, that's wrong. That's what I put on an NBME meet. That's the first thing I put on an NBME meet.
No.
It was wrong though. Okay, next. We could just even go down. Okay, Jess, now you're gonna get. Oh, yeah, someone's gonna say something.
Is it lung maybe?
It is lung. How did you figure that out? Why did you think it's lung?
I'm not really sure. I think that's like the next place that I've seen in lectures that like metastases is more like common.
Yes. Okay, that's a good way of thinking about this. This is nearly impossible, at least for me, because like once again I got it wrong with my MBME. It is lung. So you just need to know this. Osteosarcoma is going to metastasize to lung. That's the most common side of that metastasis. They won't get pedantic about details to just give you off. They'll even maybe say the patient has osteosarcoma. And they'll be like, where will it metastasize next? You got to put the lung. Liver and brain are going to be the next two kind of like things you start thinking about, which is good. So I'm going to kind of go through the different metastasis sites. One thing I want to note is this is a pretty type intel picture for osteosarcoma with the spread, like I forgot what they put in onking. It's like the sun spread, radiant spread of the osteosarcoma. It's associated with younger, patients like the 16-year-old boy in the vignette. And also, a question might come up where the patient has bilateral retinoblastoma. And they'll ask, what other cancer type are they most likely at risk for? And the answer is what? Yeah. I'm not trying to trick you. I'm just trying to get reinforces. The answer is osteosarcoma. So, like if the patient has bilateral retinoblastoma, you start thinking that they're also at risk for osteosarcoma. Just pause here for a second, because I know we sometimes talk about these vignettes and these questions like they're not human. I have met people who have had, bilateral retinoblastoma or whatever, who are blind, and also amputees because they had osteosarcoma. So when we talk about all these details, know that we're learning facts for the end point that we can help patients. And obviously, bilateral amputation and like taking out the eyes is not the best option for patients with hereditary retinoblastoma. So start thinking about ways you can help in the most dire pathologies, such as in hereditary retinoblastoma. Okay, guys, there's compassion in all of this, even practice questions. Really quick for the liver. you want to start thinking, okay, so what's gonna metastasize to the liver? You want to think colon cancer, pancreatic cancer, breast cancer, and melanoma. Okay. I want you to think of those. Melanoma also commonly metastasizes to the brain. And so when it's brain, you want to start thinking of places like lung cancer or breast cancer or renal cell carcinoma. I wanted to talk a little bit more about renal cell carcinoma because I don't think we're ever going to do a renal unit. I think we skipped that because renals soon, but not next. And at some point between GI, there's like renal and reproductive or something. We might just do reproductive next month or GI and reproductive in that order. So if you don't do renal, renal cell carcinoma is extremely high yield. It's on every MBME, it's on every CBSE, it's on every UWorld block, it's on every UWorld self-assessment. It's definitely going to be on your step one. So know what renal cell carcinoma is and how it presents. Know that they can be neo hormones because of it. So PTH-like hormone, which would change your calcium levels, and also EPO. So if a patient has polycythemia, so they'll see their patient's itchy after coming out of the shower. So polycythemia, does anyone know what polycythemia is? Polycythemia vera. It's where you have too much red blood cells. And in this case, it's because the renal cell carcinoma, and I'm speeding this up because we're almost done. The renal cell carcinoma is producing EPO, independent from the physiologic system it's in. And so it's going to drive up red blood cells through the JAK kinase, JAK-STAT2 kinase, or like JAK-STAT kinase pathway. Okay, so that's like extremely high yield. It's like mind-blowing what's high yield on the USMLE, but that's extremely high yield. Okay, and you got to know this image. I'll show you her on the screen. Know this picture. Okay, if you see this and a patient has like high red blood cells and they have flank pain, renal cell carcinoma. You just know it's renal cell carcinoma. Where is it going to metastasize? So you start thinking maybe brain, maybe lung. Okay. This is the final one, and it sucks because I know you guys probably don't like embryo, or maybe you do. I hate it. And I'll read this one because I know you guys are getting tired. I am too. A 42-year-old man with a job involving heavy lifting presents with a 2-week history of worsening lower back pain that radiates down the posterior aspect of the right thigh calf. Notice the pain is exacerbated by coughing or straining. Optical exam, he has decreased sensation over the lateral foot, weakness in plantar flexion, and reduced Achilles tendon reflex on the right side. Oh my gosh. Straight leg test produces sciatic pain at 4 degrees of elevation, MRI of the lumbar spine, posterolateral disherniation at L5 to L1, impinging on the exiting nerve root. What is the embryologic origin of the impinging tissue? Something's impinging in their spinal cord. What is the embryologic origin of this tissue? This one's a go with your gut too. So Alicia and Sreesh are like talking about this, or maybe not talking about this, or talking about something else, but now they get picked. Yeah, guys, rock, paper, scissors on screen. Yeah, Alicia.
Oh, okay, yeah.
Rock, paper, scissors, shoot. Rock, paper, scissors, shoot. Rock, paper, scissors, shoot.
Oh, stranger one. Okay, so actually we were talking about this. We were thinking like, is it notochord? Because is that what the spinal cord comes from?
Yes, it is notochord.
Perfect.
Notochord. So all you have to do is think. Exactly. You just think things near the spinal cord. All right. So like the disc, the notochord is because when you have a herniation, it's your nucleus pulposus. It's high yield for USMLE. It's high yield for you to know it's touching the notochord. Other things I'm just gonna go quickly because I know we're running out of time and I don't want to waste your guys' time. Neural crest cells. It's extremely high yield. You know, neural crest cells produce melanocytes. Okay. So they'll just give you a vignette. They'll say something like a 6-year-old man comes with an irregular bordered lesion of the nose. It's like that, like they do a punch biopsy, it's a melanoma. They decide to do surgical resection. There's like cytokeratin. They'll give you all the pedantic details. Be like, what is the embryological origin? Just neural crest cells. Okay. What else comes from neural crest cells? The ganglion that control your intestines, and also chromatin cells. So that's most related to things like pheochromocytoma, okay, and or Hirschsprung's disease. Hirschsprung's disease is extremely high yield. At least maybe even not even on use somebody step up on 2CK. So you need to know Hirschsprung's disease, start thinking neurocrest. Migration of like neurocrest cells to the intestines is a high yield, like buzzy answer for Hirschsprung's presentation. Mesoderm, that's things like your skeletal muscle. Okay. And Yeah, this is things like your skeletal muscle or your bone, I think, is mesoderm. Okay. Yeah, it says skeletal muscle, dermis, and vertebrae. So just know that I put here to know horseshoe kidney, and we're not going to get into it today. For horseshoe kidney, just know what it looks like on an MRI. Honestly, that'll get you a point. Okay, horseshoe kidney. Ectoderm, that's stuff that produces your skin, your hairs, nails, your lens of your eye. Okay, ectoderm. And then endoderm is going to things that produce things like your primitive gut tooth. And so think visceral organs. Okay, these are really abstract but high yield associations. So you can just think through what the most likely answer is when they give you a vignette like this and ask you to know the embryological organ. There's something I wanted to mention before we're done because this is the last question, but I've seen it literally on every MBME, on the CBC, and in my step multiple times, and everyone has glycogen phosphorylase deficiency. When we're doing MSK, you should think glycogen phosphorylase deficiency. How would that present? What do you guys think? You guys remember this from bio?
Like exercise intolerance, maybe like cramps.
Yes, it'll be like 32-year-old track runner has trouble running on the track. She gets tired, but after 25 minutes, she's okay. Just think glycogen phosphorylase deficiency, okay? When you're studying, get pedantic about the details about what type of there's like different deficiencies a part of that, but just remember for now that vignette, start thinking glycogen phosphorylase deficiency. And that's it. So this is like the dream part of the meeting now versus just like the ZSOA step one. Of course, we should ask questions beyond just things that we'll learn on step one and step two, because that's what drives innovation and drives compassionate research. So questions we can ask are like, how can AI be used to predict spinal surgery complications? This is a paper by a team from Mount Sinai, which is one of the best hospital systems in the US. And they looked at whether artificial neural networks were an effective way of predicting complications after posterior lumbar spine fusion. I know everyone's favorite thing, but it's MSK related. And I just want to show you that different, for example, I'm interested in neurology and neurosurgery. It's different specialties can be a part of all the different pathologies. So for example, MSK, we think about lumbar reticulopathy, like we just went through in the vignette with the herniated disc. All different specialties can interact with different specialties in different ways. And so this one, I want to show that, as a neurologist, neurosurgeon, whatever, aspiring, whatever I want to be, there's different research out there. So this one's using AI to see if we can predict posterior lumbar spine fusion complications. Not super interesting, but we found out that logistic regression is the most accurate half the time. So this is all really cool stuff, and it kind of goes into my next point, which you should write articles. The reason why I mentioned this is a large reason, like a lot of us, especially part of Dream, we're able to kind of fast track our step one. It's not because it's like, oh, they're just smarter than me or whatever. No, we're not. And frankly, I'm very dumb. I'm actually very, very dumb. But I read all the time because I do Dream, I do research, and because I have to read all the time, pedantic details about different pathologies come up very often because people regurgitate the same thing over and over again. So I know like 100 million things about glioblastoma just because I read 100 million papers that said the same thing about glioblastoma over and over again. So write based on your specialty, but make it MSK pathology related for this month. For example, Justin could write about what are you interested in, Justin?
Oh, I'm interested in cardio.
Okay, this could write about MSK and cardio. I don't know exactly what that'll look like, but you'll find something. And remember the 5 A's while you're doing that. Remember the triangle of evidence. I think you guys know these images well. If you don't, take a picture and look at it and try to understand it. I don't want to get into your time too much today. But the final thing is write with compassion. So how would this actually affect the patient? Like, why are you researching this? Like, what about this would help you with patient care? And so, for example, this spine one, it's either I'm telling the patient about this to get them excited about AI and about their posterior lumbar spine fusion, or I'm actually using this as a preface for a tool I'll create later to help patients with the predictive outcomes of how their spine surgery is going to go. It's extremely comforting for a patient and reassuring when they go undergo these kind of operations. That's it. Okay. I know this is so much. You guys will do great on step, and path is fairly hard this semester, and I know micro is too. So keep up the good work.